on the chat box will get the prize.
Okay. So
We are live, sir.
Okay. Yeah. Thank you, Sumit, and thank you, everyone. So let us start. So welcome everyone for this Kaksha online class. This is the next in line. So we have Dr. Somashiela Murthy. She has been kind enough to accept our invitation to talk on a difficult topic, which is scleritis and episcleritis. We all see these things very commonly as red eyes, and sometimes they are misdiagnosed, mistreated. And then there are a little bit of systemic associations which are sometimes missed. So that's an important topic to understand, and also an important part in your clinical practice. So on behalf of ROS, I welcome you all. We have Dr. Ashu Agarwal. She is a retina specialist at SMS Medical College, and she's a faculty there. She's an associate professor. She'll be moderating the session. We have Dr. Vijaya and Dr. Divya. So these are the two residents. They are from Udaipur Medical College, RNT Medical College, Udaipur. They will be on the hot seat. So for the sake of information, I'll just outline the format we have. So we have the moderator, we have the speaker, the guest faculty who is the part of the masterclass, in charge of the masterclass, and then we have got two residents on the hot seat. So the moderator and the residents can stop the teacher, the guru, and they can ask anything which they want. They want the guru to clarify more, or if they have failed to understand something which is there, or if they have seen something in their life which they want to ask pertaining or related to the issue, they can always stop. And Dr. Somashila can also stop and ask the two hot seat residents, Dr. Vijaya and Dr. Divya, so that to make this session interactive. So all set. So handing over this to Ashu, Dr. Ashu, and Dr. Somashila for your presentation.
A very good evening to everyone.
Ashu, your voice is very low.
Is it audible now?
Slightly better, but still we need to.
Okay. So I'll just adjust. Sir, is it better now?
Yeah, it's much better, much better. So
Yes, sir. Chala gaya upgrade now.
okay, I think sometimes it happens you need to upgrade your Zoom. So I
Yes.
think I'll start the session and you
Yes,
can
sir.
join in between. Yeah, that will be fine.
Yes, sir, that'll be fine.
Ma'am, are you ready with your slides? We can start the class.
yes, I'm ready.
Yeah. So a brief note about Dr. Somashila. She is a faculty and the medical director at LVPI, and she takes care of the two LVPIs, I think, the Hyderabad and the other one. I think I missed on that. So I'm sorry for that.
No
So
problem.
Dr. Somashila, over to you.
So it's only my duty, first of all, uh, well, it's not my duty. It's a very pleasant duty, first of all, to thank Dr. Ankit for this opportunity, also to ROS for putting me on this platform. I'm feeling a little nervous because I feel I'm on the hot seat. It's good to have Dr. Ashu on my side. And the two residents, I'm looking forward to your questions. Like I keep telling when I see a difficult patient of scleritis, so I continuously tell myself in my mind, challenge accepted. So challenge accepted today. I thought that I'll sort of relabel this instead of saying something very little bit less interesting when I say management of episcleritis and scleritis. I thought, Dr. Ankur, I'll take the liberty and relabel it as pattern recognition in scleritis to make it a little bit more interesting. So, what is this pattern recognition? Why do you even need to know scleritis? So sometimes it's very simple. You can drive, like a very nice high-end car, and you can go from point A to point B. But sometimes when you're dealing with scleritis, it seems to be as complex. At least when I was a resident, I thought it was as complex as having to drive an aeroplane. But I think with the help of your colleagues who could be rheumatologists or who could be specialists or your seniors or your professors, it's very easy as a team to get done and to treat these patients. So this is, you can make from the aeroplane, you can make it as simple as driving this small car. Once you're able to recognize all these patterns, like this lady has this wonderful patterns in her ear, once you're able to recognize the various patterns of the disease. So the learning objectives for today's class, one is that we, of course, will go on to classify scleritis in the traditional way. It's very important because it will help us get a starting point on how to recognize various kinds of scleritis. The second is the pattern differentiation to recognize between episcleritis, which I call as the better twin, and then you have the evil cousin, which is scleritis. So when you figure out that it is scleritis, you want to figure out what are the various kinds, that we keep throwing out these terms like nodular, diffuse, anterior scleritis, posterior. So slowly I will take you through all of these various entities. Then it is not that the entire wastebasket or the entire laboratory of investigations is advanced for these patients, but we tailor the patient's investigations requirement when we see the clinical picture ahead of us. And finally, we manage the patient. So let's try and go through some of the major parts. I'll try my best not to go through each and everything, but more or less the important points. So coming to the classification, this was most of the, Divya, can you tell me? Of course, the answer is also at the bottom, but can you tell me who was, well, it was Professor Peter Watson and Sohan Singh Harry who published scleritis, but Divya, can you tell me that who are these gentlemen? Do you know? Is Divya there in the hot seat? All right. So, yeah. Okay. Do read up about them. So, Professor Peter Watson is considered the guru of scleritis. Okay, where is he from? I think Ashu was asking you.
Ma'am, I request Dr. Divya and Dr. Vijaya to show
British, ma'am, Britain.
Okay. All right.
I cannot see Dr. Vijaya here.
It's okay. We'll keep pulling them up onto the screen. So, Divya, it is a case of you should, offense is your best defense. Before I ask you a question, you should ask me a question. That's a trick. So when it comes to the classification, these two gentlemen, they are considered as gurus. Professor Peter Watson is considered as guru for scleritis, for many inflammatory diseases like Moran's ulcer and so on. He had published in that. Of course, he's no more. Professor Sohan Singh Harry, who's none other from our own India, from Punjab. So he went on to describe various entities, including optic neuritis and so on, of which he also was a co-author in this presentation, in this classification. So scleritis is very simply classified as anterior and posterior. So the midpoint of that is probably the pars plana region, you can say. So anything anterior of that is called anterior scleritis, which is very easy to see. Clinically, you can see the patients, they come with the features. Posterior scleritis, little bit more difficult to make out. You need certain tests and you have to have a clinical suspicion. So under anterior uveitis, you have the non-necrotizing and the necrotizing type, which we'll come to a little bit. And under the non-necrotizing, you have diffuse nodular necrotizing with inflammation without. So I'll come to examples of all of these. Also have some additional sort of semi-classification or newer entities, which we discovered along the way as we kept treating patients over a period of time, that even after surgery, you can induce scleritis, you can incite scleritis. So that is called a surgically induced scleritis. That can be both surgically induced necrotizing scleritis or surgically induced diffuse scleritis also. So these are examples. This is a case of diffuse anterior scleritis. This is a case of a big nodule, which is apparently very congested looking. So this nodular scleritis. This is what an inflammatory necrotizing kind of region looks like. There's a lot of tissue breakdown, ulceration. And this is that so-called entity where you have necrotizing scleritis without inflammation, which we used to see frequently in patients with rheumatoid arthritis. It's not so frequently seen. And remember, this publication is way back from 1976, when none of you were born. So coming to the second part of my presentation, I said that
Yeah, ma'am, on behalf of residents, I want to ask one question. That
yes.
Surgeries
Hey, I thought you're on my side, but anyway.
Ma'am, which surgeries can cause this surgically
induced necrotizing scleritis? So the commonest surgeries that were earlier described was pterygium surgery, extracapsular cataract surgery. So that was because sometimes there was some uveal show, or your you're operating in the region you're operating very close to the sclera in the case of pterygium. So you do stimulate the tissue to start getting inflamed. But of late, you can see surgically induced nectarine scleritis even after vitreoretinal surgeries sometimes. But these are the top two: cataract surgery, especially SICS or extra cat. The SICS is majorly done now, and also pterygium surgery.
So, ma'am, cautery can play a role in this?
Yeah, so cautery, very correctly you said, Anshu, that excessive thermal damage to the sclera can either cause ischemic necrosis, so that will not heal well, or it can set up an inflammatory cycle where there will be thinning, inflammation, and ultimately sometimes you have to start the patient on steroids, or even sometimes you have to force to do a patch graft, as you correctly mentioned. So there are two entities, which is episcleral inflammation and then scleral inflammation. So this is the photo is from Kansky. And in this particular image, what you see is the cut section. And what they have shown so beautifully is in Kansky textbook is that the focus of inflammation is ahead of the sclera. So sclera is this thick white layer here, the grayish white layer. And in episcleral inflammation, it is ahead of that. So obviously in the human being, you can't get a cut section like this. But what you can get is an anterior segment OCT, or clinically you can see. Clinical features include that the patient has quite a red-looking, crimson red-looking, either a nodular lesion or a diffuse lesion, but not pain. So not having pain is characteristic of episcleritis as opposed to scleritis, and it easily blanches with the use of phenylephrine. So here's a patient of mine who had history of this recurrent redness over here, had very mild pain, had said, yes, doc, I have some pain. If I would ask him, he said, yeah, I do have pain. So what I did is even otherwise we dilate the pupil to examine the retina. So put the dilating drop. And you'll see that after putting the dilators, especially phenylephrine, most of the area has blanched out. These are the normal looking vessels. I also had a suspicion of scleritis because of this thinning region here. But that was just a thin area of, the watershed area where the rectus muscle insert. So that is just that area. It is normally thin. So this is a case of episcleritis, diagnosed because the patient's symptoms were very minimal and also because it blanched so well with phenylephrine. Is episcleritis associated with systemic severe disease? We all know that when someone has scleritis conditions, have are harbingers, so to speak, of a grave systemic disease. For example, you can have granulomatous polyangiitis or rheumatoid arthritis and all these other names which I'll take in a while. But what about episcleritis? So luckily for us, most of the episcleritis conditions, or at least large majority of them, 95% of them, do not really have any systemic associations. On the other hand, they may be having local ocular conditions. For example, you may have a patient with recurrent blepharitis or with Demodex blepharitis. So these patients do present with recurrent episcleritis. It has been shown now. So always look at the local lids and conjunctiva. Rule out other such conditions that could be predisposing the patient to recurrent redness of the episcleral tissue, including the use of drops, anti-glaucoma medications, and so on. And the best part is that episcleritis can recur as many times as it likes, but it is not associated with visual loss. So, as I said, that some of these patients can have some systemic association, but this list actually shows that a lot of local conditions or drug reactions. So these are some of the reasons for having episcleritis. It's extremely rare to have in pediatric patients, but for some of the cases which have either rheumatoid arthritis. So it's very rare in a young patient to have episcleritis. In those patients, I would rather think of ruling out blepharitis or something like that. So ultimately, the diagnosis of episcleritis is clinical and it is not lab-based. You don't need to do, as a resident at least, strong message I'd like to give to you is that there's no need to do any serological investigations to look for systemic diseases. On the other hand, make sure that there aren't any lid conditions like exposure, patient is using topical medication. Make sure that these are not happening. I have had occasional cases of patients putting some agent in their eye, like something from the kitchen or any other toxic agent in their eye. So they were malingering just to seek attention. So when you cannot explain the pattern, do stretch your mind to something rare like that. So again, I've already said that no, don't investigate. Only very rarely have I investigated patients with episcleritis. and which I'm coming to soon. But whatever investigation I do for scleritis, I do for episcleritis, the very few cases where it is bilateral, it is extremely recurrent, and nothing is happening even with topical corticosteroids, and I might have to use oral agents. So only those cases. So in the large majority, I just don't investigate in case of episcleritis. From the management perspective, you can use whatever is the minimum medication you can use to get it better. For example, start off with lubricants or NSAIDs. That's not working, then use low potent steroids. Sometimes you might have to use potent corticosteroids as well. And usually the condition will subside 99% of the time. Of course, they may come back with recurrences, then again you repeat as required. So that is my mantra for the case of episcleritis. So is Divya and Vijaya, is that right? Any questions? Vijaya, maybe it's your turn.
Ma'am, how can we differentiate VKC Horner Tranta spots from scleritis?
That's a good question. VKC Onotranta spots are dense white, sort of almost like calcific looking dots, which are present at the limbus. But before you go to the examination, you would have already had history, which is very different. So those would be patients who have chronic eye rubbing, maybe pediatric patients have pigmentation of the conjunctiva. And if you flip the upper lid, they might have papillae as well. Whereas in the scleritis or episcleritis patient, the main feature would be sort of a diffuse congestion, either episcleral or a deep congestion, for example, scleral. And for the scleritis patient, you'll have very severe pain, which won't be there. So on a Tranta spots, usually it is easy enough. It won't be a isolated finding. You will always have it with allergy. So that is how, when you put the clinical picture together, you cannot confuse it with episcleritis or scleritis. Does that answer your question?
Yes, ma'am.
Okay. So the same Kansky picture again. So on the other hand, and I want to tell you that when I was a resident, I never understood this. I didn't understand the previous picture. I didn't understand this picture also. Took me a while when I started practicing to realize that what they were showing here is that, of course, there is superficial inflammation, but also the scleral coat is thickened. So there is scleritis. This is a case of scleritis. So when you imagine that the deep vessels are involved and when you're examining, so you will see a much less brilliant red. So it is not brilliant red. The hue is brownish. It is because it is below it's deeper below the conjunctiva as opposed to episcleritis, which is more superficial. So here in scleral inflammation, both superficial and deeper layers show edema. So I said that I'll show you cases of typical characteristic cases of scleritis. Now look at this particular picture here. So this is a lady approximately 55 years of age, comes with history to my clinic with history of sort of a dull aching pain lasting for several months now, and she's been going here and there. Sometimes people give her NSAIDs, oral and topical. Sometimes people give her steroids. It gets better and then it gets worse again. So she was in my clinic. I asked my fellow to take a look at her. My fellow came back and said that this looks like episcleritis. So what else should we do? Divya?
Ma'am, blanching test?
Yeah, very good. So you can see pupil is already dilated. So we already put blanching agent and she still has a lot of dilated vessels. So what you should do is you should watch out for me because I'm very tricky. So I don't give you complete information. So before you do anything else, you must examine the patient pick up the eyelids. And this is not about, believe me, it's the same patient. So if you look at it in the primary gaze, this is how it looks like. Pick up the eyelid, ask the patient to look to the left side, to the right side, down and up. And you can see that everything. So this is after blanching. So now, would you call it episcleritis? Divya, what is your diagnosis?
No, ma'am.
Okay, what would you diagnose it as?
Ma'am, scleritis, diffuse scleritis.
Diffuse what? Diffuse?
Anterior
Very good. I think you can
scleritis.
stop the class, Anshu. Anshu, they got it. So this is a case of diffuse anterior scleritis, as you mentioned. And the trick here is that never look at the patient without looking at all the regions. If you look just in the primary gaze, you'll also be confused, like how my fellow was. So how do you think, since Divya, you answered, now how should we approach this patient? What should we do next?
Ma'am, we have to take the full systemic history, like to identify the cause, because scleritis is associated with systemic history.
Okay.
And
All right.
we can go for B scan, fundus
You can examine the
imaging
fundus.
also.
Yeah. We don't
Yeah.
have to do B scan unless you're thinking of posterior scleritis as well. So we can examine the fundus, and if you think that there's a lesion in the back which looks like posterior scleritis, then we can consider B scan. Otherwise, it's not needed. And we can correlate with the patient's vision also. The patient has excellent vision, retina looks normal,
Yes.
does not have
Okay.
pain on movements. We are ruling posterior scleritis. So diffuse anti-scleritis. The next case I have was Vidya, any take
Ma'am,
on
your
what
voice
diagnosis?
is breaking.
So like,
Ma'am, I would like to interrupt you.
okay.
It's not clear and it's
Yeah, I think the voice is breaking, ma'am. So
Okay. So what I'll do is I'll turn off my video because that will give me some bandwidth for the audience. Okay. Is my voice clear now?
yes, ma'am. Yes, ma'am.
All right. So what I'm showing here is 3 pictures of maybe similar case, maybe different case. So actually it's a right eye, left eye, I think, of this patient. So when this patient looks a little up, Ashu, am I clear?
Yes, ma'am. You're clear.
All right. Yeah. If I'm not, please interrupt me like you told me earlier. So here you can see that there is a lot of inflammation. And in the epicenter of this, there's an area where you can see the uveal hue. Right? Now, when I ask the patient to look down, what I can see is a lot of thinning and also this outpouching or a staphylomatous formation. This is the other eye of the patient, which is showing a large sort of a congested nodular lesion. So can you describe the sort of anatomical diagnosis for this patient? Either Divya or Vijaya, anyone?
Ma'am, necrotizing scleritis
Yeah, very good. Again, with so again anterior. That's what I'm,
anterior.
so, yeah. So you don't have to say it though. So yeah, this is a case of necrotizing scleritis. However, in the other eye right now, maybe the patient had unilateral disease for a long time, had progressed also to the staphylomatous stage, and now, which often happens, it's not unusual. The patient now comes to us when now it is affecting her good eye. And in this right eye, she had, I think, secondary glaucoma or something like that. In the good eye, now the patient has just started developing a nodule. So if I look at the left eye, I'll call it nodular scleritis. But if I look at the right eye, because of this thinning and so on, it becomes a case of necrotizing scleritis. Or there is inflammation, but the likelihood of this patient having a systemic disease is very high. And in that, it was a female patient in her 60s. So definitely I would investigate to see if the patient, either the patient could be having rheumatoid arthritis or the patient could be having some of the lab tests positive for rheumatoid arthritis, because the systemic disease may not be very active at this stage. Even though the scleritis is active, the patient sometimes don't have that much of systemic disease as per what you would expect. So in such severe case, but still systemically, there is nearly nothing. So look for these diffuse bluish red areas and look for scleral thinning, look for the UV exposure. So this is a case of necrotizing scleritis. And this one here, if this was only IOC, then it would have been nodular scleritis. There is a role of using the slit and also using the red-free filter. So the slit, what it shows is that in a case of scleritis, you cannot really see the posterior end of the slit. So you can see that both anterior and posterior can see, and suddenly it disappears. Because obviously you cannot see the height of, you cannot see it because it's masked by the height of the nodule. So that is how it shows it's blunted. The posterior edge of the slit is blunted. And if we have a patient with an area which, so it looks like it's very congested here, but less congested here. But when you use a red-free filter, so this yellow arrow where it's pointing out, the same correlating part on the red-free filter shows that the capillaries have dropped out. So you know what happens in the etiology, in the pathophysiology of these patients, that there's an end arteritis which knocks off the capillaries. So therefore, if this patient continues to have inflammation, then this is the areas where the patient can now start getting thinning and so on, because the capillaries have been knocked off. So using the red-free filter in diffuse scleritis will give an indicator that this may not be the first episode. The patient has had episode in the past, capillaries have dropped out, and it's getting serious now. So you can use a slit beam as well as a red-free filter to augment your clinical examination for the pattern recognition, what pattern does this patient have. So this is probably what cases you might see, very angry looking, congested, severe pain, very engorged vessels of a case of diffuse anterior scleritis. Sometimes you can have lesions just involving the cornea, starting to involve the cornea. Sometimes, so this is not elevated, it's not staphylomatous. This area is naturally thin in our eyes, and therefore, when there's inflammation, you'll see this bluish girdle. This particular patient also has this peripheral scarring in the cornea because they would have inflammatory cells at the time of activity. And one more pattern that you have is that in diffuse anterior scleritis only, you can, in front of your eyes, see these in the watershed areas where the capillaries are ending. So these areas undergo ischemic necrosis. Next, you'll start having the thinning of the sclera over here. So these are some examples. All of them are anterior scleritis in various stages. These are some examples of nodular scleritis. One nodule here. This patient also has a nodule of scleritis. This is a small pinched out ischemic infiltrate in the nodule, and this is in high magnification, the same infiltrate. Not getting too much information from red free, except that there's no blood supply in that ischemic infiltrated area. So this is not infection. You'll see and you might think it's pus. It's not. It's actually just that the tissue is dying over here. Some more examples of bilateral diffuse anterior scleritis. This is a patient who, after investigation and also based on her history, we could ultimately reach a diagnosis of relapsing polychondritis. But in the beginning, she is just a case of diffuse bilateral anterior scleritis with peripheral corneal involvement, peripheral infiltration of the cornea. So watch out for these patients who have corneal involvement because they are more likely to have systemic involvement as well. So this is the same patient. So this patient had a very long course. In fact, I have a follow-up of this patient of 17 years, 17, 18 years now. And we published this case. This is a patient who first came in 2000 something, 4 or 5, and had this bilateral diffuse anterior scleritis with the peripheral corneal infiltrate. As she kept progressing, we started on oral steroids, we started on immunomodulators. And in one of her follow-ups, she did show this typical saddle nose deformity. And she also had thickened ear pinna because of the cartilage involvement, because of inflammation of the cartilage. And based on the criteria used to diagnose relapsing polychondritis, she fell into that criteria. So we could diagnose her as a case of polychondritis. And she needed multiple medications to stabilize her condition. And even her systemic condition is very active. It's quite a sad case actually, but for 17 years, she managed to keep coming for follow-ups and she managed to maintain excellent vision in her eyes, though systemically her condition was quite bad.
Ma'am, can you hear me?
Yes, I can.
In these cases, which antimetabolites you usually prefer?
So our starting point was we actually gave her infusions of IV cyclophosphamide because this was way back in the early 2000s. And that was the main drug we used for severe cases. So IV methylprednisolone, IV cyclophosphamide, maybe 4 to 5 infusions. And then we kept the patient on, of course, oral steroids initially. And we tried cyclosporin on her. We also had to shift to azathioprine. So many agents were used in her case. And finally, in 2017 or something like that, she also received biological, she received adalimumab. That also didn't help her much. And ultimately, most recently, the patient was started on tofacitinib, and that actually helped stabilize the condition. So Divya and Vijaya, what I'm talking about is the evolution of immunomodulators over the years. We started off with only steroids and cyclophosphamides, and we would use agents like methotrexate, azathioprine, cyclosporin, just go around with these agents only. Then we started using mycophenolate mofetil and tacrolimus, oral tacrolimus. And of late, the tendency has been that in cases which don't get controlled easily, we start the patient of biological agents, or we start which can be intravenous, or some of them can be oral also. So this has been sort of a 20-year revolution in the management of these conditions. Especially rituximab is one of the newer agents which has been helping much. So I'd like to know, Ashu, at what time I should stop my onslaught of information because it's already 8 o'clock. Yeah, so I'll try my best, and both Divya and Vijaya, it's your job to tell me that this is too boring. Please keep quiet.
No, ma'am,
it is very interesting, ma'am.
So this was
till, another half an hour also. There's no issue.
Sure. Yeah. This was a 60-year-old lady who was diagnosed as full-blown GPA. So where are my hot seaters. So hot seaters, what is GPA?
Granulomatosis polyangiitis.
Okay, was earlier known as?
Wagner's granulomatosis.
And why was its name changed? We don't know. Why did we change its name? It's a bit of history here. So maybe a trivia question. So change his name because Wegener's was involved in Nazi war crimes. So we don't want to attribute any disease to anybody like that. That's why it's called by so the pathology actually, the name explains the pathology. So it's granulomatous inflammation and it's polyangiitis. So then multiple systems are involved in that. So we had a patient who was already diagnosed as systemic granulomatous polyangiitis. She had lesions in the lung, she had renal involvement also. She was already on oral steroids. And unfortunately, when she came to us, she had developed a fungal pneumonitis because she was on long-term immunosuppression. So, and to top it, she presented to us with a necrotizing scleritis. So this is a patient looking down. What you can see is very angry looking. And over here, the peripheral cornea appears to be getting just about involved and thinned out. But we persisted, we did not. So she was sent for a patch graft, but we persisted, we did not put on a patch graft. We waited for the antifungal therapy to go on for a while. And we again started the patient on immunomodulators. And slowly over a period of time, the patient resolved very well. So this was, I think, after 3 months, the entire area where there was severe scleritis, all of that resolved with the help of. Later, we started again a course or two of biological agents for her. She received 2 or 4 infusions of infliximab. And also she was on oral medications like mycophenolate morphine to be precise. And unfortunately, after being extremely well controlled, this patient finally succumbed to another systemic infection. So this is the story of patients who have very advanced GPA. And that's the importance of, sometimes I feel that's the importance of detecting that if a patient comes to us with scleritis, which of these patients are likely to have these systemic severe immune-mediated disorders. And by us intervening and finding out early on, we can sometimes help save the life of the patient. So that was about GPA. This is about a much more common disease. So Vijaya, this is a no-brainer. What am I showing here? Haath pair. Haath aur pair mein kya hai? So the image on the left
Rheumatoid
is.
arthritis.
कहीं लिखा है क्या मैंने diagnosis? So describe what you're seeing. So the image on the left shows the hands, and you can see
Swan neck phenomenon.
Yeah, very good. Swan neck deformity of the hands, of the thumbs actually. And then the image on the right. So if you compare the ankle, the right ankle versus the left ankle, you can see that there's effusion, there's swelling of the right ankle. This is an elderly male patient with rheumatoid arthritis, and there's a young patient who has activity. So you're more likely to have this kind of patient come in, at least if you're practicing in towns or in cities. Whereas sometimes you might have the patient come in with this kind of condition also in a wheelchair, unable to walk, very advanced disease. And if this kind of patient is being wheeled into your clinic, especially in a scleritis clinic, it is bad news. It means that there is a lot of severe ocular involvement. Whereas if this kind of patient walks into your clinic, this is the correct time. You can try your best to catch the disease early on, both the systemic disease, and treat the patient. So this is not of, this is an identical picture, but it's not of these 2 patients actually. I don't have the matching pictures of different patients, but similar to what these 2 patients had. So this is what we're saying. It's necrotizing because the tissue is breaking down. The sclera is literally destroyed and become thin, and slowly you can see the staphylomatous formation. But there is very minimal inflammation. So this is that necrotizing without inflammation. But actually remember that there's always inflammation here, at least at the molecular level. So you had mentioned posterior scleritis earlier, and already we went through some of the clinical features of, I had mentioned it, posterior scleritis. So Divya or Vijaya, so when would you suspect a patient with posterior scleritis? What is the pattern in those patients?
Ma'am, painful.
Yeah. So history would have pain, and one more in the history. What else?
Diminution of vision.
Excellent. Yeah. Then painful eye movements.
Pain.
Yeah. What would you see?
Ma'am,
or what would you not see? What's a negative finding? You wouldn't see any inflammation in the front of the eye.
Yes.
In fact, the eye looks very silent. You won't see anterior uveitis, nothing. But the patient is very clear about severe pain, especially on eye movement, and decrease in vision. So you have to examine the retina. And what do you see there?
Ma'am,
You will see
scleral
lesions.
folds.
Maybe, maybe not. You will see lesions that look almost like a choroiditis. So you will see something like retinal. It looks like
Ma'am,
very edematous swollen tissue. Yeah.
inverted T sign, ma'am.
Yeah, I'm coming to that.
On the scan, yes.
So it's not inverted, it's kind of like a sleeping T sign.
T.
It's on the side T sign. So you will see on the fundal examination, you will see almost like the closest is like a choroiditis. It looks like elevated, large area. Then if you do FFA for these patients, this is done for documentation more than anything else or for the complete diagnosis. Then the pattern will be similar to what you might see in choroiditis. It's really hard to differentiate. Of course, we should have OCT, which I don't have for this case. But the give way is when you do B scan for this patient. So this is T sign. T sign means that the optic nerve itself is one end of the T, and the arm of the T is the fluid that you see in the scleral space, in the subscleral space. Because there's so much of thickening of the sclera that you will be able to see fluid that has collected there, and that causes the T sign. So you may not have a complete T sign sometimes. So you have to have this high on your mind as a case of what it could be is posterior scleritis.
So, ma'am, can you show your previous slide again?
Yeah.
Dr. Divya or Dr. Vijaya, can you tell the fluorescein angiography findings in this picture? Can you explain them? What are these dark areas?
The doctor is asking you about
Ma'am,
the disc. You can start with the disc and then go on to these dark areas. Yeah.
You can start with the disc, as ma'am told.
ma'am, hypofluorescent areas are there,
Yeah.
suggestive of vasculitis, non.
Why do you say vasculitis? Maybe Dr. Anshu, you
Maybe
could.
There is a leakage in the area of the disc. Okay. And also the normal choroidal flush that is present is absent here, which is due to choroidal inflammation. And in vasculitis, basically, we see the staining of the vessels. We cannot see that here. So we will not
Yes,
go
yes,
towards vasculitis. It is going towards choroiditis. And this is also due to optic nerve edema and choroidal inflammation that is happening.
okay. Thank you.
Also, when you describe the
Leaking.
FFA, yeah, talk about leaking, blocked fluorescence, bright
vessels.
areas. Yeah, so start with the disc, the blood vessels, and then talk about. So for example, you said vasculitis. You're giving a diagnosis of the FFA, whereas you need to describe what you feel the FFA. So we'll not go into more details there. So that was a sort of a roundup of various kinds of patterns that you see in episcleritis. We don't have much of a pattern, but in scleritis, including posterior scleritis. One entity that we've not covered is infectious scleritis. So in the Indian context, I think infectious scleritis is important because compared to Western literature, where about if you take any large serum, so they have less 4 to 5% patients will have infection. Whereas any large Indian series, including the ones we published from LVPR, have almost a 14% or even an 18%. So that means 1 out of 6 patients, if you are running a scleritis clinic, 1 out of 6 patients walking into your clinic would have infection. So two very important factors in history for me is one is history of trauma and second is history of recent surgery. So when I have these two factors, I do try my best to make sure that I'm not missing an infection. Sometimes infections can be very obvious. Like this is a patient who had wooden stick injury. So this is the primary lesion, a lot of necrosis going on there. This is another lesion, which is away from the primary lesion. You can see that there's a lot of discharge. There is pus at the base of the lesion. There's slack. So this is very obviously infectious scleritis. But sometimes, despite the obvious nature, it is sometimes hard to get the microorganism because these lesions are not heavily loaded with the infectious agent. In fact, here I think it was fungal, but we had to do 2 or 3 scrapings and testing to finally release the diagnosis. This is another patient who had undergone pars vena vitrectomy, and in the olden days, and the patient was under treatment as a case of surgically induced necrotizing scleritis because the ports were showing thinning down. But when the patient came to us, we also noticed that there was this purulent material and slough. And also the patient never improved on steroids. So we thought that was against surgical induced necrotizing scleritis. So we took this material and we scraped it. And we took the scrapings and we subject to microbiology. This actually grew nocardia. So post-operative scleritis or even trauma, some of the common organisms can be fungus, can be nocardia, but of course bacteria can be everywhere. So sometimes an infection you can have the agent which is involving the cornea and then going on to the sclera. Now this is very obvious. There's no rocket science here that the patient would have fungal ulceration, very bad case that has gone on to the sclera. But sometimes it's not so obvious. For example, one more postoperative case of vitreoretinal surgery. This patient had a nucleus drop and then underwent nuclear removal, removal of the nucleus of the drop nucleus, and then secondary IOL, and somehow came back.
Your video is paused. We can't hear you.
I'm so sorry. So, okay.
Ma'am, you're.
Am I audible now?
Yes, ma'am, you're audible now.
Okay, thank you. So I was talking about the second picture on our right side, which again shows one more post-operative patient who has multiple nodules like this. So this patient has history of surgery. So history of trauma, history of surgery, multiple nodules like this one here. So these are all indicators of infectious scleritis. So can I have any questions for me now?
Dr. Divya, Dr. Vijaya, any questions? Or anyone in the audience? You can write in the chat also. Ma'am, I think you can proceed. Ma'am, you're not audible.
Yeah.
I think
Yeah, actually somehow
from
my PowerPoint got stuck, so I'm just trying to sort it out. Yeah.
There's a question from Apurva. She wants somebody to explain the FFA findings. I think she's still stuck with the old FFA we had.
Apurva, what we'll do is that we'll skip that because it is a very old FFA also, which is going, it was the FFA for that particular patient. So maybe sort of beyond the scope, and or we'll take it up in the very end after we go kind of offline so that we don't sort of derail the whole presentation.
Then there is a question how to diagnose nocardia, and the management of same.
Yeah. So diagnosis of nocardia in terms of clinical presentation, it is not easy. So we'll have patients who come in with infectious scleritis, like these two examples. This is also nocardia. So having multiple pus points and having lesions which they are skip areas. So you have one pus point here, there's nothing, and then there's another pus point, and then there's something more here. So that is one, you can't really diagnose that it's nocardia. It could well be fungal, it could well be bacterial. So have any other bacteria. So nocardia by itself, you cannot diagnose it. You have to do microbiology for this. And you can see these thin, long beaded filaments, which is suggestive of nocardia, which is nocardia. Treatment for nocardia is always amikacin 2.5% eye drops, which are formulated, used every 1 hour initially. You can also put the patient on oral ciprofloxacin or co-trimoxazole orally, which also has some scleral penetration. So this is the treatment for nocardia. It's very challenging entity to deal with. I wanted to bring one more challenging entity to your notice, that this was a child, 14-year-old, who had a history of waxing and waning of episodes like this, and had a very whitish looking lesion with surrounding inflammation, very cheesy looking lesion when it was excised. So excision biopsy, although it did not grow anything, definitely showed on histopathology the Langhans giant cells, kind of giant cells with a lot of fibroblastic proliferation and lymphoplasmacytic infiltration. And then this patient, based on the histopathology, was highly suggestive of Mycobacterium tuberculosis. We started the patient on ATT, and then the lesion completely resolved. So what I'm trying to say in a nutshell is that you can have these chronic cases where the bugs can be very different from what is put, what you've been studying in the Western literature. This is yet another patient. So we do have patients with Hansen's disease. This is a patient who had all systemic features of Hansen's disease and had this limbal nodule, which was actually communicating with the AC also. So when we excised, we did an excision biopsy, and also we put a scleral patch graft because the wall of the eye had become tectonically weak. The AC was shallow and there was hypotony. So this lesion was teeming with leprae bacilli. So we started the patient on treatment for that as well. Yet another case of infection, but viral infection. So the patient had in a lesion on the forehead, and 2 months later presented with this episcleritis or scleritis actually. And I don't know if you can see that, but there are also lesions on the cornea, these whitish lesions on the cornea. So the lesions on forehead correlated with herpes zoster ophthalmicus, and this was nothing but a case of scleritis with the corneal lesions following herpes zoster. So we initially started oral steroids. There was not much improvement. Then we started antiviral agents, and slowly the patient's condition resolved till we had a complete resolution of the scleritis. Am I audible?
Yes, ma'am.
So in conclusion of this part of the presentation was that what I've shown you is various patterns which helps us to describe and differentiate various types of scleritis. If we say, okay, it is episcleritis, so I said you don't need to do investigations. If we say it's scleritis, then if it's a diffuse anterior scleritis, the association with systemic disease is low. But on the other hand, if it is necrotizing scleritis, maybe with corneal lesion, the association with systemic disease is very high. And in the case of injury or previous trauma or history of recent surgery, then you must also think of an infectious etiology. So based on the pattern that we recognize, we have to formulate our management strategies. So I'm concluding this presentation, or the first part for now, and I'll stop sharing.
Thank you so much, ma'am.
There's a question in the chat box, ma'am, how to differentiate between nodular scleritis and flectanular nodule.
I wish I had a picture. I do have, but it'll take a long time. So a flectanular nodule is a sort of a tongue-shaped lesion which has vessels. The appearance just looks like inflamed conjunctiva. So this lesion starts on the conjunctiva and spreads across the limbus and sometimes also goes into the cornea. The patient does not have severe pain and it's a recent onset. This nodule very rapidly responds usually to topical steroids. So that is flectanular nodule. On the other hand, scleritis, I've just gone through it. So nodular scleritis patient will have high pain and will not improve very easily just with topical medication. And the lesion itself with the vessels and all will never cross onto the cornea. You'll have corneal inflammation, sort of inflammatory cells or something like that, but never a vascularized lesion going onto cornea. And it will not heal with corneal scarring. It will heal with thinning of the sclera. Whereas flictin will never cause thinning of the sclera because it doesn't involve the sclera.
I think that clarifies the differentiation between the two. Anusha, are you there? So any questions do we have from the audience or our hot seat residents, Divya and Vijaya?
Sir, the FFA finding, which ma'am was telling
Okay.
in the last.
So in FFA, ma'am.
So do you want me to share the FFA again?
Ma'am, they want to know
Yes.
if the FFA that is hyperfluorescent in the beginning, will it become hyperfluorescent later on in this?
That's right. That's what this FFA showed actually. Initially, there was blocked fluorescence because of the involvement. And then later there was leakage. And that's why and then pooling. So that's why the entire area was hyperfluorescent.
I have one question for the hot seat, Dr. Divya and Dr. Vijaya. Have you understood how can we differentiate between episcleritis and scleritis? It has been a wonderful presentation where ma'am has in detail explained how to differentiate between the two and the various etiologies which could be causing them and how can we manage them. Also, there would be an interdisciplinary management that has to be done in this case. So I want to know whether you understood this or not.
Yes, ma'am.
So I'm just putting up the FFA because I think it's good that we generated some interest. It doesn't matter, Ashu, if it is your specialty.
Yes.
And this is a very old FA, very old really. And maybe you would be the better person than me to explain how an FA is supposed to be read. So that'll answer the question even for, I think, Anusha, who asked the question in the audience, and as well as Divya and Vijaya, because maybe they didn't answer it to the up to the mark for the exams at least.
So in the early phase, as we can see here, there is a lack of the choroidal flush in the hypofluorescent areas, but later on these are hyper because the staining is taking place, and as ma'am correctly said, there was a leakage and a staining. So this mainly explains that this is the area which is diseased, the pathological area, and it also tells us, as you can see here, the vessels, these are above this area. That means it is the choroidal area which is
Over
involved,
here.
not the retinal. And
So this patient has spillover. So it's not just scleritis alone. This patient also has choroiditis. And so just doing an FFA alone will not rule in a case of posterior scleritis. You will have to have a B scan for you to establish that there is thickening of the scleral coats as well. So if you, in fact, if you do an FFA alone, so this is suggesting more like a sort of a large area of choroiditis or something like that. There also seems to be some macular edema maybe or some swelling in this area as well. And you can see on the B scan that there is massive thickening of the entire coats. But only when you do the B scan at the cut going through the optic nerve, you can very clearly see the subscleral fluid. So based on both our clinical examination, partly on the retinal examination, but certainly on the B scan, we are finally labeling this patient as posterior scleritis. Now, Ashu and I know that from the management perspective, there may not be that much difference. We would do almost a similar gamut of investigations, and the treatment also would be, once we figure out that, you know, what are the investigations showing, the treatment also would be very similar for both the entities.
ma'am, can you also explain how the T sign looks on the B scan?
Yeah, so as I had mentioned, it's not exactly inverted because a T sign is something that you make. So it's sleeping on one side. So this is the arm of the T, the lower portion of the T, that is the optic nerve. And in this area, there is fluid over there, which is it is seen. I'm not sure how well it's seen for you. In the other cuts,
it is nicely seen, ma'am. You can see
yeah,
the
in the other, yeah,
yeah.
in the other cuts also you can see some fluid,
Yeah.
but it's not going through the optic nerve. So when you take the cut through the optic nerve, then you can see this fluid over there. So this fluid is the top part of the T. And so it is a T like this. It's a T like this, or rather, let me put it this way. No, even I'm getting, yeah, something like, so this one is the optic nerve, and it's always getting inverted. I don't know. I'm getting confused. So, but you get my point that this is the optic nerve and then this is the fluid. So that's why it's called T sign. It's a good point. Next time I probably should just put it in the way a T is supposed to be, and so nobody's confused anymore.
Yeah. I think you can put the part of T in first
Exactly.
as a T, and then incline
yeah.
T as a T.
That's
so
right,
it becomes
yeah.
from here like this to like this.
Yeah.
So
after a while, you think everything is obvious.
And I think the
yeah.
FFA, we need a lot of pictures to actually
Of course,
describe
yeah.
an FFA,
Of
right
course.
from the early arterial phase to the
Correct,
late
correct.
phases. So
Correct.
this probably is not the right forum to describe the FFA, at least in this particular kind of disease. And the idea of putting FFA picture was to just put up the prototype of the FFAs you can find in these diseases. So that I think I will have to understand, and we'll maybe keep a separate session on reading an FFA sometime. So that will help people. So can we have the question for the residents, ma'am? So whosoever answers first will get their prize.
Yeah, actually, my question was pretty much what Dr. Anshu had already mentioned. The question for residents basically is the same, is that can you list out the top 4 differentiating features? So the must-haves, like when you say it's scleritis, what are the top 4? When you say it's episcleritis, what are the top 4? Yeah, top 3 bolo chalo.
So you'll have to type the top 3 features which can differentiate scleritis versus episcleritis, right?
Yes, that is correct.
So anyone who types that, so blenching, pain, and vision loss.
Is that the first?
Yeah, that's the one which has come. Pain, diminished vision, and no blenching on vision loss. No, there's something. So basically, the answers are usually blenching, pain, and vision loss.
Yeah,
Is that okay, ma'am?
That's good enough.
So the first 2 will get the prizes. I'll take a screenshot of first 2, and somebody will contact you guys to kind of distribute the prizes. Just a moment. Yeah. So we already have 2 answers. I think the first one is from Divya and second is from Anusha.
So Anusha was actually paying a lot of attention.
Yeah. And Divya was on the hot seat. Anyway, I think it's good that the residents were also a little interested and well read, I guess.
I think so. Residents are very smart. I was very dumb as a resident, I must say. So just that I wanted to sort of correct you that that L.V. Prasad Eye Institute is where I come from, and I'm on deputation at Shantilal Sangvi Eye Institute, which is in Mumbai, India, and they're 2 separate entities. And it's a very exciting new place that I'm at in Mumbai city, very pulsating, very exciting city. I've studied here, and it's good to be back. So I invite all residents, if they want, they're more than welcome to visit us here at Shantilal Sangvi Eye Institute in Mumbai.
Actually, what
And
happened was
series cases
LVPI.
also.
So LVPI after the Hyderabad, I was thinking of Vizag, and I remember that you were not in Vizag. So I
Right.
got little, perplexed at that point.
No problem. It gets me a chance to explain where I am. And also, if you want some excitement, folks, you can come and see those scleritis cases. Sometimes they really bring a lot of excitement, challenges, basically. I've kept out a major part. I've not talked about investigations and I've not talked about therapy, though I have mentioned it several times. I've deliberately kept that out because we wanted to get in the basics first.
Yes, ma'am. So we can have a more detailed maybe sometime later where we can talk about the investigations in detail about the scleritis and episcleritis, more so for scleritis, and then the management. And I think with this, we'll come to an end of this class. Thank you, Dr. Somashiela, again for accepting our invite and doing such a nice, elaborate, full of pictures, which is actually required to understand these 2 diseases, which are very common. And I thank Dr. Ashu for moderating this session. And thank you, Vijaya and Divya, for being with us. And thank you, everyone who attended. And thank you, Untaught guys, for supporting us in this webinar.
Thank you very much, Dr. Ankur. And thanks for having me.